Hello, and thank you for inviting me. I just wanted to introduce myself. I'm Bill Pomputius. I'm the medical director of the Infectious Disease and Immunology Division at Minnesota Children's Clinics Hospital. I'm also the director of the ASP program, and to let you know what that means right now, it's me and a part-time pharmacist. So resources and their utilization is always at the top of my mind. And in interest of full disclosure, one of my longtime collaborators, Steve Grappatine, who some of you knew as an ASP pharmacist, has moved to the West Coast. So this is very much on my mind. So what I'm going to do is talk to you about some impressions I've gathered over my 5 years of ASP missteps, mistakes, false leads. I think we're making progress, but I've come to develop a philosophy which may be of interest to you who are not in the hospital field. First of all, I want to maybe describe a little bit the environment that I work in. For those of you who don't work in hospitals, hospitals are very tribal places. They're really a collection of nation states. I deal with the nation of neonatologists, the nation of surgeons, the nation of hospitalists. The ASP team acts in some ways like an ambassador from the very strange world itself of ID to the rest of the, we think sometimes uncomprehending world. But I think that's changing. I think that people are starting to internalize ASP guidelines significantly. So I'm going to just tell you what traditionally has been done in hospitals to control antibiotic use. And first I want to say I'm in a pediatric hospital where 75% of the patients either are admitted for infections or possible infections or develop infections during the course of their hospitalization. When you factor in the fact that maybe half the antibiotics that are used in the hospital at any given time are inappropriate, you realize that's a lot of antibiotic ordering, a lot of charts, a lot of prescribers' shoulders to look over. It can't be done easily. Ideally, you would want to have platoons of infectious disease consultants or platoons of pharmacists to circulate at any given minute of the day to make sure that every single antibiotic prescription was appropriate. Not possible. So this has been done, we've approached this program through a number of ways. And this is what I would call the traditional ASP approach. We've used something called prospective audit and feedback, where after a 40 to 72 hour period where we allow practitioners to use the antibiotics they feel fit for the clinical situation at hand, we then look over their charts, we make recommendations. Sometimes the recommendations are made face-to-face, sometimes they're made virtually through text or emails. Some hospitals have depended heavily upon restriction of antibiotic use or pre-authorization. And I have to say that this is perhaps more the case in hospitals where there is, for example, an ID fellow who is available 24/7 to answer phones and give permission to use antibiotics. We have obviously always depended upon prescriber education, but I want to emphasize that this doesn't mean lectures and grand rounds. I personally feel this is actually a very poor way to convey the knowledge we want to convey. I prefer the concept of what we call academic detailing. And I don't know, for those of you who have worked with detailers, we're taking what is effective about their approach, but stripping away any commercial bias. Basically giving people bite-sized bits of information immediately usable at the time when they need it. Guideline implementation is a very important part of what we do. Fortunately, I don't have to do it myself, but I've been involved in formulation of guidelines for osteomyelitis, skin and soft tissue infections, UTI treatment in the emergency department setting. Finally, there are IT applications. And this is, I think, will be in the future a game changer because, as you know, in ASP programs, it's not enough to change things. You have to measure what you intend to change and then measure the effect of the change that you've affected. That involves a lot of data crunching. And the more access you have to data analysts, and I want to say It's not a data analyst, because there are many different databases to analyze and data analysts who have expertise in one field or another. The more access you have to those people, the better off you are. What I want to emphasize is this basically means that I'm dealing with a potentially very labor-intensive endeavor. I can't do this by myself or with one other pharmacist. There are many models for how people get by this resource, this demand resource crunch. We have pharmacists that go out to the floor, abstract, then present the abstracted chart data to physicians to review, or the pharmacists themselves directly communicate with physicians, for example, when there are bug-drug mismatches, when inappropriate antibiotics are used for the organism determined to be the cause of the infection. Telehealth has been used very innovatively in places like Utah, where the Intermountain Healthcare System includes scores of hospitals separated by hundreds of miles. There are very enterprising ID physicians who have turned themselves into telehealth antimicrobial stewards, so they can basically transport themselves virtually to the bedside of a patient or to a pharmacist who is the sole ID presence in a rural hospital with no ID consultant presence whatsoever. In my world, in pediatric stewardship, there's actually a very interesting experiment which I would refer you to if you have any interest in this, called Handshake Stewardship, which has been pioneered by a PEDS ID specialist, Dr. Sarah Parker, at Colorado Children's Hospital. This actually involves face-to-face daily rounding with each surface. I believe she calls it Handshake because it's a very personal approach where you're actually talking directly to the ordering physicians, and as you can see, this requires a great deal of time. So I want to say there's no universal solution. Solutions are dictated by resources available. Much of the literature in the ASP world is generated by academic centers who have resources that community hospitals may not have. And so solutions that seem to work for a place like a large academic medical center will not necessarily be what a rural center would choose. And I want to emphasize, my own experience points this out, is that resources are not fixed. You may start with a team of so many people and then they move, or funding is reduced, and then what do you do? So the challenge is basically not to do less if you find your resources curtailed, but to do things differently, more strategically. And I like to think about hand washing as maybe a similar situation. There was a time when hand washing was infection control's problem. You know, people aren't washing their hands enough. What are you going to do about it? Well, infection control practitioners aren't going to wash people's hands for them or stand by the bedside to remind everyone entering a room to wash hands. So what started initially as education, like ran rounds, or secret shoppers, basically undercover infection control folks watching who wash their hands and then reporting back to units, or maybe depending upon the Hawthorne effect, infection control may be watching you, so best wash your hands. That actually is very effective in the short term. But what I want to emphasize is that the solution to hand washing, and we've made a lot of progress at Children's, was not so much bringing more infection preventionists into the arena, but rather making it more of a collaborative effort. Instead of infection control's problem to solve, it was sort of the community's puzzle to solve together, almost like putting together a puzzle, you know, during Christmas or whatever. So how was this done? We did things like we disseminated a mobile app so that anyone could observe and report back at any given time, maybe 5 or 10 minutes a day. We found that with continuous observation and continuously being observed, people's attitudes began to change. They were actually internalizing what they had been taught for so many years in our case. And we're actually starting to see a significant shift in hand washing percentages, which I think goes to show that our job as stewards is not so much to be stewards on behalf of the people that we are working with, but to somehow inculcate what we feel as stewards in them, so they become stewards in their own right to pass that on. This is going to be a cultural thing that is going to hopefully propagate itself. Maybe an analogy might be seatbelt use. If you go back to the 60s or 70s, minority people used seatbelts. They weren't available, or when they were available, people chose not to use them. Now it would be the minority of people who don't use seatbelts. It's something that's been internalized. So as I was preparing this talk, I was looking at what the Joint Commission requires as part of an ASP team, an Antimicrobial Stewardship Program team. And it was interesting. They said, well, ID physician, that sounds good. Always good to have an ID physician to decide what appropriate antibiotics are, although I would say parenthetically that there's often a lot of disagreement among ID physicians about what appropriate antibiotics are, uses. Infection preventionists, very important because some of our outcome measures include things like C. diff or the emergence of resistant bacteria, and they're the ones who are charged with keeping track of that. Pharmacists, absolutely key to any program success. But finally, practitioner. I thought, practitioner, what does that mean? And then I realized that maybe inadvertently JC was pointing to what may be our salvations. The fact that we're not an ASP team operating within a hospital. We're actually the spearhead for multiple ASP teams, and it's our job to basically recruit and form collaborations. Understand that hospitals, I said, are nation states. There's a lot of silos, and our job is to work among the silos to break down barriers and basically enlist people to work with us. And this is where I come up with my policeman versus coach. I really detest walking into a room and someone saying, oh, here's the antibiotic police. You know, we're doing this to you. What I prefer is people walking into a room and having people say to me, we understand there's a problem, we're not sure what to do about it. Maybe you can help us figure out ways that we can solve the problems we see in our own practice. For example, in surgical practices, what do we do with kids with perforated appendices? What kind of antibiotics do we send them home with? How long? How do we shorten the need for IV antibiotics? Well, I can help you with that. So I want to emphasize, I think that instead of being a policeman, an antibiotic policeman, our job is to be sort of antibiotic coaches. And here are some of the attributes of coaches. They focus on performance of a defined task. They define the agenda, and I want to say, up to a point, I'm dealing with people who are fiercely independent, value their autonomy, and I think the best projects that I've been involved in are ones in which the people I worked with in other departments said, this is our problem, this is a project we want to bring to fruition, how can you help us bring this about? So it's their project, their success, and they're, as a result, encouraged to do more along the same lines. The returns on coaching are obviously improved teamwork. Just the joy of being in a functioning team is reward itself, as you probably have gathered in your own personal and professional experience. And antimicrobial stewardship works better. We actually see concrete outcomes, and I'll describe some of the things that I'm doing. Some modifications are needed. I, for example, don't have a captive high school football team to coach. I have a bunch of fractious healthcare providers. So what I've done, spent a lot of time doing, is trying to identify people that can be ASP champions, can be my substitute, my stand-in, perhaps independent ASP practitioners themselves. And I've done this through a number of ways. One is I've identified people that I've been involved with in small initiatives here and there. For example, I mentioned the surgeons and the post-appendicitis antibiotic initiatives. And in fact, I found some of my best allies with people that gave me the greatest grief. And that's what I would encourage you to do, is when you're looking for champions, find the person who engaged you, not necessarily positively, but negatively. They care enough to push back, to argue. They actually may be, if you can win them over, your best collaborator. The second thing is, besides enthusiasm, was finding someone with a desire to improve personal or group practice, which is becoming more and more the case as people actually get reimbursement for doing QI projects, or they're required to do it as a condition of employment. I'm looking for people who are self-starters, you know, who can take a project and work with it themselves with a minimum of feedback from me, encouragement from me. And finally, and perhaps this is most important, remember I said hospitals are places where there are silos, where there are nation states. You need to find people who have street credibility within the division and group you're working with. Surgeons, I am not going to convince a surgeon to change their behavior, but surgeons will convince other surgeons to change their behavior, and I see it all the time. So, I mentioned that I'm not a policeman, I'm a coach, but I'm also a couple of other things. I'm also an ambassador of the world of ID to the world of neonatology, or the world of surgery. I'm a cheerleader. I'm encouraging people to be proud of the successes, even the small successes they've achieved, because that feeling of pride and ownership translates itself to developing more projects and hopefully more success. And finally, I would have to say my job is to remain a listener. Over the last 5 years I've been doing this, I've seen my role change as I've learned more, but also as different demands have been placed upon me. So I'm going to conclude by just saying that it's a combination of tutelage and collaboration. What I want to do is basically, well, I should say, I was going to end by telling you some of the things that I've been doing. What I found is that as I've gone out to look for champions, I've actually found people who are independently working on what I would consider very basic antimicrobial stewardship programs on their own. For example, looking for someone in neonatology, I discovered that there was an entire world of process improvement that involved putting hard stops in antibiotic treatment durations that I never even knew about. So now I have an ally with already a fully developed, well, I should say a developing program who already has buy-in from her colleagues. I've identified other divisions with resources greater than mine who have overlapping concerns. For example, Children's has put a great deal of time and effort into quality and safety. And it turns out that they have devoted pharmacists, they have data analysis, and I can work with them on projects that we share. For example, one of the projects that's of great interest to me right now is limiting the concomitant use of vancomycin zosyn, which, as some of you know, has a particular, an idiosyncratic nephrotoxic potential, which is of great concern to us, especially in our more vulnerable children, those in cardiac surgery. I have also found that the laboratory is a great ally, because what I've learned over these years is that good antimicrobial stewardship actually starts with good diagnostic stewardship. If you give clinicians bad or incomplete or confusing lab results and they act appropriately on them, you still end up with inappropriate antibiotic use. So what we're working on now, for example, is the more rational use of blood cultures. We know that we're under drawing and our blood culture volumes are inadequate, so you're probably not identifying as many cultures through culture bottle growth as we should. And finally, I mentioned it's so important in the ASP world to measure the effects of what you're doing. Unfortunately, we don't have a lot of metrics that help us with outcomes. C. diff is one, C. diff incidence, as you know, C. difficile. Incidence is related often to inappropriate antibiotic use. But much of this is also, many of our metrics are actually due to our process. How many people are using our guidelines? How often are our recommendations acted upon? And this is where I actually use the resources of the committees that I work with. For example, the Guidelines Committee, their job is not just to formulate guidelines with my assistance, but also follow up on how those guidelines are being used, fine-tune them so they're used more effectively, or change them as necessary. So that is all I have in terms of general words of wisdom on ASP. I have actually 2 slides, which I should, let's see, how do I advance? Let's see. Is it down? Arrow, or? There you go. This is just a slide from the Sharps Collaborative, which is pediatric hospitals, and the FT is allocated to ASP. You can see we're all over the board. These are hospitals between 200 and 500 beds. There appears to be an emerging consensus of what may be adequate, but you can see from this is that the distribution of practitioners is very varied. So we're not an antibiotic police. We're certainly not ID Light consultative service. We're not the primary driver of improvement or the sole steward. I want to say we're enablers. We act as collaborators. We serve the people to encourage all to become stewards. And I will leave you with that.